Hi, today we are here to talk about unplanned extubations and ways to prevent that in the NICU. We have another collab with RT and RNs to talk about our stabilizer process, stabilizer change, tape change, and how we go about doing that in the NICU.
So as RTs, your role is critical and crucial in preventing unplanned extubations and ensuring optimal ventilation.
Ideally, 2 RTs are managing the airway. So that means one RT is helping hold the tube, the other is changing the tape or stabilizer, and the nurse is then helping maintain patient comfort and position. If there is no RT available, they're at a delivery in the ED, and you are the one who has to help with the RT, help do the stabilizer change, then we're gonna talk through that process as well.
So step 1 will be an airway timeout. So make sure that you have all your supplies at the bedside ready to go, whether it's your tape, your neofit, your gauze, and of course before any movement or procedure, confirm that the ET tube is secure. And always work in this scenario with a second option, so an RT or an RN for patient safety.
Make sure that if your patient is on the IVH bundle, that you both are discussing ways to maintain midline positioning for the infant. So never deviating head from midline. So if the head has to turn to get at some tape with adhesive remover to remove, making sure that you're helping log roll the patient. And as part of this timeout, as the nurse, making sure that you've maximized comfort and sedation for your patient so that it's a smooth process. So that could be extra medications, swaddling if appropriate, hands on the infant, and a hand hug.
So for step 2, we'll do skin prep. So for this, it'll be the 2 RT approach, where one RT is holding the tube against the gum, when it will be removing the device.
And the RN can help maintain patient positioning if your patient is especially active, or helping hold from down here to be out of the way, or just watching and monitoring vital signs to make sure things are going smoothly.
It's very important that you remove all the old tape or device completely. And to do this, you must utilize the adhesive remover wipes to maintain skin integrity. Please clean and dry skin and then apply the adhesive or mastosol or benzoin.
All right, everyone use your imagination. This baby is less than 2 kilos, which is why he has a neofit on. It may not be appropriate to swaddle those babies. You could use a cloth diaper or the straps of your positioning device to help control patient comfort.
Beautiful. So next for the step 3, we'll go over the entirety of the neofit securement device. So of course, as the RT, always verify your tube depth at the gum before and after securement. Ensure that the ET tube is centered and not pressing on the gum. So first things first, I'm going to have my RT over here hold the tube against the gums. And I'm gonna get my adhesive remover ready to go out of the packet. So what I'm gonna do next is I'm going to undo my Velcro. A little tricky sometimes, so make sure you're not pulling too much. So now that's free, so now the RT can have full control of the airway. And now I'm going to go ahead and use my wipe to remove the adhesive portion of the device or the neofit.
Sometimes it's hard to see while doing this through the portholes of an incubator. We're using a warmer just so you can see on the camera. And so you may be asked to help do the side that you're closest to if the person on the opposite side can't see. The purpose of the adhesive remover is to help maintain skin integrity and not cause any skin tears while removing the tape or the stabilizer.
Afterwards, please make sure the skin is dry before you apply your benzoin or mastosol. So of course you would take it out, crack it, and apply to the skin, upper lip, and other side of the cheek. Give it about 10 to 15 seconds to allow it to fully dry before placing on your neofit. So you remove the back, the back stickers of the neofit itself. Ensure the prongs of the grip are facing the tube. And then from there, ET tube tape or your 3M purple dry multi-port tape. And you will tape, essentially, as you can see here, where it will go into the neofit. Now, if you're not moving your neofit up or down for changing of tube placement, then you can use your previous tape. So after this, I'm going to go ahead and apply the NeoFit around the tape. Not too tightly to where I can't actually go in and inline suction, but secure enough to where it won't come up and down. Your second step is to use your lollipops, which also come in your NeoFit packaging. The head of the lollipop should cover halfway of the NeoFit padding and also the cheek for more surface area. Harbor gloves. Okay.
Now we need to make sure that the tube is in the same location that it was, so that's a double check as well.
So for NeoFit, the pads, of course, should not be covering the eyes, nares, or nose entirely. From there, a big issue that we can have with this is that over time, as the kid is mobile or moving, it can actually begin to beak up. So what you'll see is the portion right here that goes on the top lip will actually begin to beak and become pointy. That will move the tube up from its current location. That could lead to a possible UPE.
So at handover, nurses and RTs should both be doing eyes on tubes and any invasive lines for RNs. And so that includes placement, securement device, and making sure that the adhesive is adhering everywhere, so watching out for that beaking or sides coming up. And we're back with a different baby. This baby is greater than 2 kilos and is appropriately in a warmer. And I have just helped remove the ET tube tape method, and I am securely holding the tube to the mouth as an RT. And Vinny here is going to put the tape back on.
So make sure you have your Y, your H, and your pretty piece already cut to the bedside, ready to go. So after I crack open my master saw and apply to the cheeks, upper lip, let it dry, about 15 seconds, I'll get my Y piece ready to go onto the patient.
Same role for the bedside nurse if you're the third person, assisting with patient comfort and positioning, making sure that their hands aren't getting too handsy, so the RTs have an optimized setup for placing this tape.
So I'm on the left side of the patient, so I will have the tube placed in the left corner of the mouth. So I'll have my RT or RN help me assist to the other side. So where the little separation point is in the tape, that will go here in the corner of the mouth.
Same with the stabilizer, just make sure it's not covering or causing at risk for a pressure ulcer in the septum or nares area.
From there, you will wrap the Y tape under the ET tube to prevent downward pull. Got it. I have tube. Make sure you communicate tube positioning and who has control of the tube and airway at all times.
As you'll notice, the tape method is not centered, so you will tape the tube to either side of the mouth, often alternating with each change, whereas the NeoFit stabilizer is always a centered.
And then at the end, a little tab. So it's very easy to undo at the end, if need be.
Courtesy tab for the win.
Okay, up next will be the H tape. And this H tape will be wrapped in the opposite spiral starting at the same point. So you have a longer end and also a shorter end. The shorter end will go on the side where the tube is, because obviously you have less surface area to cover on this side of the face.
And obviously before you get all the tape on, making sure that the tube, when moved over prior to taping, is at the same location as it was once previously.
So I will put the middle piece of the H piece right over the tube. Make sure you cover your other tape with your current H piece. You will then go, same thing, underneath and around in a candy cane fashion of the tube to prevent, once again, a downward pull.
And obviously your baby will be connected to the ventilator tubing, whereas our little model baby is not. So you might have to work under and around some of that tubing. Just do so carefully to avoid tugging.
Okay. Now finally, it is time for your pretty piece. This piece is designed to cover more surface area. So it should be kind of designed in a little mustache kind of fashion. And once again, I should be covering your previously placed and cut tape. Nice and smooth.
Awesome. So now, as the nurse, we've done all this. I want to reposition my baby. Now we want the RTs to be the ones to give the cue. So you guys will kind of make eyes at each other, make sure both are ready, and then the RT will be the one to count and give the cue. We're going to go towards you, Vinny.
Okay, so I have tube. So on the count of 3, 1, 2, 3.
Bravo. Then we can reposition with all the great developmental aids that this baby might require.
So the RT's role is airway safety. So please communicate clearly, check depth before and after, and always escalate concerns to your bedside team or LIPs immediately.
And as the nurse, your role is to escalate and communicate with RT promptly. So notice any concerns that we've talked about, loose tape, beaking, excess secretions, please escalate to your RT. And then during rounds, if you've got a lot of secretions, that's the perfect opportunity to escalate about maybe the baby qualifying for atropine drops to help with those excess secretions. We're all trying to work together to decrease our unplanned extubation rate and increase our patient safety.